we know that without ending tobacco, we cannot end TB. So today, our topic is about the leadership in addressing TB, tobacco co-epidemic. And we're happy to introduce that the Dr. Singh and sorry, let me see. Sorry about that, because this cell phone was from one of the staff, and I can't open it now. Give me 1 minute. About the Singh. He is the public health practitioner with a doctorate in public health and a master in primary health care or management. Currently, he directs the Asian Pacific tobacco control at Vital Strategies in Singapore. He provides technical assistance to governments in the Asia Pacific, advancing public and One Health initiatives. As a member of WHO Civil Society Working Group for NCDs, Dr. Ban has over 25 years of experience in policy development, program management, and research in tobacco control, NCD, TB, HIV/AIDS, and health system strengthening. He served the Union for 17 years, lastly as the regional director for the Asian Pacific Office. So let's welcome Dr. Tara, please.
Please don't believe whatever she just mentioned. But just I'm Tara Singh. I'm nothing, just trying to be one of your key allies. So let me introduce myself. Actually, I'm Tara from Nepal. Always, I'm sure you know Nepal. How many of you know the Nepal? Yeah. Okay. At least Mount Everest is there. I think that's one of our big the icon at the global level. So in this session, actually, I'm trying to share our experience, what we need to end tuberculosis, and how we need to really work together to eliminate tuberculosis from our community. So that's why in this conference, this is one of the great the session that we have, and I have 1 hour here. So it's a really big challenge to keep you here, for 1 hour. So let's make it more a bit interactive, and just what I'm trying to put some questions to all of you and convey some message why we need to integrate TB and tobacco. So let me share couple of my slides. So it's a leadership in addressing TB tobacco epidemic. How we can see the leadership from what perspective? I think that's really important. So leadership in action, leadership in policy making, leadership at the community level, leadership in managing the TB, leadership in managing the comorbidity, leadership in financing. So there are many aspects that we need to think when we really target our goal to end tuberculosis. So in this, I don't have any conflict of interest. I don't work with the tobacco industry. I don't work with any alcohol industry or any other pharmaceuticals. So I have no any conflict of interest. In my session here, in my presentation, briefly I will highlight. You all know. Just I'm trying to highlight here to some data for the discussion. So the problem of TB and problem of tobacco at the global level, and what's the linkage between TB and tobacco. So we have all great leaders. I'm really happy to see here many tuberculosis experts. We have experts from Bangladesh, China, Dr. Okado, and you all here. I think this is something that we can discuss really how to ensure the tobacco control in TB control programs. So finally, we can also discuss about some action point. So what's the problem now? I think I don't want to really highlight this thing, but you can see. So sorry, I didn't. Put the data. It may be a bit old, but it's still relevant. So we all know that we have more than 10 million tuberculosis cases, and also every year 1.3 million, over 1.3 million people die from the TB. So this is something that we are here to ensure that nobody will die from TB. I think that is something we are here to make our commitment. If you look at the burden of tobacco is over 1 billion smoker around the world. It's a huge. And the tobacco smoking is one of the biggest public health challenges that we have today. So it's a challenge for non-communicable disease, it's a communicable disease, and also for overall our environments and the development program. Over 8 million people die due to tobacco-related disease, so including some of them is from the TB as well. So when we look at the correlations, so there are about 1 million, actually, I would say, it's related to the TB, related to tobacco, smoking or tobacco use. And 16% of the death is really contributed in a TB population due to tobacco use. I think this is something of big, the issues we need to understand the problem. So once we have this, then what are the risk factors? If you look at these are the WHO, I just put some of the countries, the example here. WHO identified 5 key risk factors. So if you look at among them, smoking is either in some countries leading risk factor, in some countries the second leading risk factor, in some countries the third, but it is one of the major risk factor of tuberculosis. So for example, in Indonesia, if you look at Indonesia, 1/3 of the TB cases is due to tobacco smoking. It's the number 1 risk factor. And similarly, in a country like in China, the alcohol and the tobacco smoking is is a big risk factor for TB, and some in many other countries, Myanmar, Philippines, and even India. So we really need to think, of course we need the TB medicine, we need the good diagnostic tools, and we need the good management, but we need to look at really how to really address the TB problem and eliminate all of these, the risk factor from our community. So that's the big thing that we need. You as a leader, we need to make some action. Just to summarize exactly the previous slide, in India, if you look at almost 8% or 10% of the TB, is because of tobacco smoking. Indonesia, as I mentioned earlier, more than 1/3 of TB cases is actually because of the tobacco smoking. That is 300,000. Indonesia is estimating it's about 1 million of TB cases each year. So of the 1 million, over 300,000 TB cases are because of tobacco smoking. So if TB control program, if they don't integrate this, if they don't address the issue of tobacco smoking within the regular TB control program, I don't think we would be able to eliminate tuberculosis from our community. So there should be a really good coordination, collaboration, and cooperation among the programs and between the programs. So this is something related to the death, TB-related death due to tobacco. So, for example, China is leading, so over 25% of TB, the TB death because of the tobacco smoking. And Nepal also, I'm very happy that we have colleagues from Nepal here. So in Nepal as well, more than 16% of the TB deaths because of the tobacco smoking. So then you can see in some other countries, So it's globally, I think tobacco smoking is one of the key risk factors for TB. So if you look at the association between TB and tobacco, whether it's only, it's not only at any point. It's all through the pathway from from diagnosis, even from the onset of TB symptoms. We can see the impact of tobacco smoking at a diagnosis in all the way up to throughout the TB treatment. If TB's population continue to smoking, I think that you can look at the problem here. So it's even the higher relapse rate, the delay in TB diagnosis, also the disease occurrence, and it's all the steps all the way. So we cannot say that TB or smoking has a problem or impact only on the TB outcome, but it's actually the whole cycle of the TB. So that's a big issue, a big concern. And this is very interesting, this slide, that one of the studies that we did a long time back in Nepal to look at the relation between smoking and delay in TB treatment and delay in TB diagnosis. So if you look at this, the slides, so the current smoker, of course, the overall it's a significant delay. It's a more than 3 months delay to seek the TB treatments or TB diagnosis. But if you look at among the current smoker, it's more than 4 months. More than 4 months that they are undiagnosed and they are living in the community without any diagnosis. So when we talk, one of the key our agenda is to cut the chain of transmission. But if people with TB, they are still undiagnosed in the community, so how can we manage this? So therefore, we need to really integrate smoking cessation or smoking program or campaign, and also build a good campaign to highlight the relationship between smoking and the TB as well. So that's something we need to also think. So when we talk about the leadership, what is leadership? I don't know. I'm not an expert of the leader. I'm not a politician. So what I have learned from many politicians from different parts of the world, whether they are at the local level or the province level or state level or the national level. So what I've learned, we need it's not a political leadership, we need leader. The leader can be anyone who really direct us, who really guide us to do the impactful work in our community. So that we need leadership, we need also make them accountable. That is very important. If leaders are not accountable, if we are not accountable, like for example, I'm attending this conference since 2003. I missed only one, and that was in person in Guadalajara. So I don't know whether I'm making any difference or not in my community. I think we need to also think. We participate in the conference, we attend the conference, we know what is there, we know the knowledge, we know how the people are working in the different settings, whether it's a high burden or low burden or middle income. But after we go back from here, do we do any action to address any of the issues? We don't need the big action, we need a very small action, but that needs to be really carried out at the community. So as a leader, it's not only the politician, we all are leaders. So we need to make some action, we need to be accountable. The third point is sustainability. So TB control or tobacco control or any public health program is not a project. We don't have a defined time. We do this, finish, and then bye-bye. No. This is something that whenever we initiate something, we need to see a long-term sustainability of the program. And as a leader, we need to identify our really clear visions or the mission, whatever you can say, whether that's going to be sustained or not in our community. So any action that we do, we need to look at from the different perspective of the sustainability as well. So one of the key things that I'm trying to highlight, I have started actually from last year only, legislation. So in tobacco control, in alcohol control, in a non-communicable disease community, always we talk as a leader, the leaders should really think about the legislation to make the governments accountable, to make the civil society accountable, to make the donors and partners accountable. Everyone, every stakeholder needs to be accountable. So how can we make it? We need to have the national or subnational legislation. It's a law. So, for example, in my country, in Nepal, we have a big problem. Always TB control program, if you heard from the TB control program, if you listen to them, one of the big challenges always they highlight the private sector. So how can we really bring the private sector? So it's not about the people who work in the private sector, they know about TB. They know about the good treatment, they know the diagnosis, everything. But what they see, they don't report to the TB control program. They don't follow the standard guidelines and all. It's completely up to them. So if we have a national legislation to bring everyone together, on, so that everybody can follow the same standard and same protocol, and also we can make them also accountable for the TB or tobacco control program. So I think this is the time to really highlight the issue of legislation. It may work in it may not work in a developed country. I think it's already, still we need the legislation for tobacco control in any country, in any setting, but I don't know for TB, but in a high burden setting, especially in the Asia, for example, India or in Nepal or Cambodia or Indonesia or any country, I think we need the TB legislation as well to ensure that everybody's role and responsibilities have been clearly identified and also followed. So second part is the capacity. I don't need to talk about this. When we talk about the accountability, of course, we need to ensure the action. But we need to ensure that the leaders should ensure there is a sustained capacity building programs and ensure the standard protocols and all the implementation rules and regulation in place. The last part is sustainability. How we define this is, one is the resources. Definitely we need resources. We need to have a good monitoring and evaluation system. When we talk the resources, it's not always we go to the donors, Global Fund, for example, USAID or JICA or any DFID or anything. We need to, as a leader, we need to try to find out the domestic resources, whether there is any domestic resources available or not. I'm sure in any countries there is the domestic resources. We need to trap, we need to identify, we need to find out. For example, so in tobacco control, I'm a tobacco control advocate. We always advocate the governments to increase the tax and the price on tobacco products. And it can be done also for any other unhealthy products, alcohol, for example, sugary drinks, or there are many others. So if we make the governments convince or accountable to increase the tax, some portion of the tax can be used for the public health intervention. It's a huge money. It's a huge, huge money. I'm sure that you have heard from the Indonesian ministers. So, the TB budget, the resources has been significantly increased in Indonesia. And he is trying to look at the domestic resources from the different sources. Tobacco tax is one of the source. I think something we need to also look at. And when we go back to our country, we need to talk to our governments, we need to talk to our politicians and push them to increase the tax. So we have a win-win, double win. Increase tax, that will really help to denormalize or convince the smoker to quit, or they prevent the smoking among the youth or the children. If cigarettes or tobacco products is got expensive, definitely we have the best evidence from the different parts of the world. It's one of the significant, the public health measures to reduce the tobacco smoking. So that money can be used for a TB control program. So for example, in Nepal, and also in Indonesia, in Nepal, the government has established a national health fund. And about 25% of the tobacco tax, the money, it goes directly to this National Health Fund. So that's, up to now it's there, but what we need to do, the program managers or the people, the advocates, they need to meet the minister and convince the minister to use that budget for TB control program as well, or for any other, the lung health program. So that's something we need to identify ourselves as a champion, and also try to find the domestic resources and for a greater sustainability. So always we cannot go for the donors and partners. Always we cannot go to the WHO, or I don't think WHO is the donor partners, is a technical agency, but any bilateral or multilateral partners. But we need the Global Fund support and others. At the same time, as a local leaders, you need to look at how we can sustain our program in terms of financial resources in the long term. One of the example I would like to give you here. In Indonesia, we have started a long time back in 2009, 10 is more than a decades. Some intervention at the local level. Even there was a very limited national policies and programs to address the TB and smoking, and also especially for smoking. So what we did, we worked with the local mayors, the local leaders. At the city levels, they have a mandate. In the Indonesian setting, they have a greater autonomy at the local level. The city leaders can make a local legislation, can make a local planning and budgeting, can make a local, evaluation framework, and can also approach to the national and international donors as well. So, using that great opportunity, we approach the mayor. I think our biggest champion in tobacco control and public health programs. He was the mayor. He served the 2 terms as a mayor in Bogor city. Now he is the vice minister of Ministry of Home Affairs. So he moved to now national level. And just we met a few weeks back to he's still very keen to support public health program and the program that that is needed for the community in Indonesia. So under his leadership, what we did, we have a local comprehensive legislation for tobacco control first, and a comprehensive the policies to integrate TB and smoking. So it's the only city that, so it's a really good example that we have established in Bogor city in Indonesia. What we see, and similar, the lesson that we have learned has been expanded to other countries in the region. Bangladesh is one of them. In Bangladesh, there are more than 30 mayors. They establish a Healthy Cities Alliance in Bangladesh. So we have really also some good movements going on in Bangladesh, in Vietnam, and some in other countries. Philippines is another good example as well. So we need to look at not always with the national political leadership. We need to look at where we can do something at the subnational level. Any action that we do, everything's at the subnational level, at the community level. People who work at the community, I think they know the local leaders very well. So we need to make them accountable, and we need to build the local leaders' capacity as well. Therefore, I think if we really identify something at the local level, we can make really big difference. I think that is something we need to do. So what action? So just to connect TB and smoking, what action we did? I think Dr. Linian also here, Dr. Okada also here. At the union, we have tried to really establish, provide the key the intervention that can be done or carried out at the local level within the regular TB control program. When I say that within the regular TB control program, it doesn't mean that you need any additional resources. It means within the regular TB services, no need to have a separate smoking cessation. So any DOT provider, they can just offer a very brief advice within a minute or within 2 minutes. And that advice should be also integrated with the regular TB advices or communication or information, whatever. So we in 2010, some of the members, as I just already named, we established a working group at the union to develop a guide to support the countries for implementation. And we name it ABC. It's a very simple intervention. What is A? That is just we ask the patient with TB when they visit TB clinics, do you smoke? Do you use tobacco? Very simple. Second, brief advice. Whether they smoke or they don't smoke, doesn't matter. If they smoke, the DOT provider needs to provide the brief advice just to quit. If you quit, just convince them. And the second, if they are not smoker, also there is a message: remain as a non-smoker, and also avoid the second-hand or passive smoking. So that is also another the brief advice. Finally, the cessation support if it's a condition, if the local health facility, if they have some additional information, for example, leaflets, or nowadays technology we have, if there are any online materials that supports the people to quit smoking, so they can also offer this additional information that we call cessation support. So it's easy to remember, A, B, C, and easy to implement at the ground level, and doesn't require additional resources. The training can be integrated within the regular TB program, so for any type of program. So I think this is something very simple intervention, doesn't require the scientist, doesn't require the sophisticated diagnostic tools, doesn't require any medication. It's just a local action by the DOT provider. Can be done in 1 minute. In some occasions, it's less than a minute. So by applying that A, B, C, we have piloted this program in several countries, including India, Indonesia, South Africa, Nepal, and many other countries later on. Sorry, Dr. Okada, I didn't put the findings that we have from the Philippines. Also Philippines, we have many other countries as well. So in India, what happened? If you look at the burden of smoking among the TB community, TB population, especially among the male population, 89, almost 90% of the TB people, they used to smoke. They were smoker. If you look at the prevalence of smoking among TB among the male population in India, 89%. Indonesia, almost all. Everyone smoke. Smoking is a really big issue. In a TB community, among the male population, look at the 97% smoking prevalence among the males. But compared to the general population is around 65%. Similarly, in South Africa is 43%, Nepal also quite high, about the 80% smoking among the TB population. So that's something we need to really look at, whether this is really a problem or not. We can see it's a real problem. And we have an opportunity because we have a TB clinics. And the TB, the patient, they visit almost either, it depends on the country settings. There is a regular interaction between TB and the health community. So those are the opportunity we need to really tap and use to make a comprehensive, the package of TB elimination. What's the result? So the intervention until 6 months. So just we put here for example, like only the quit rate, whether through the ABC, whether the smoker, in TB population, they quit or not, and what's the quit rate. And the different, as I mentioned here, Bangladesh using the community-based DOT that time. I don't know now. At that time, it was a community-based dots. So that means when you look at the community, there is a more interaction between the volunteer, community health volunteer, and also the TB patient. More interaction. In India, it's just the 3, 4, 5 the intervention only. So at the first month, at the 0 month, at 2 month follow-up, 3 month follow-up, 5 month, and the 6. So there were around 5 interaction only between TB people and the health providers. In Indonesia, it's a monthly interaction. So that means 7 times during the TB treatments, there was 7 interaction between TB, the people, and the health provider. In Brazil, China also the same as India. I think, Dr. Lina, please correct me. Yeah? And in Brazil, there was only one session at the first visit. One session means the health provider offer their smoking cessation at the enrollment. That's all. But if you look at the results, in Bangladesh, more than 80% quit rate. As I mentioned already, because there was more interaction between health provider and the TB patient. India, Indonesia, and also China is a very similar, the results that we have. In Brazil, even one session at the enrollment, still we have good quit rates. 50%, it's a big number. So it means it works. Smoking cessation within the TB control program, it works. What we need we need action. We need to simplify our, the advice or communication messaging and integrate within the TB population, program. Benefits. So Kamran and the colleagues, they did this study in Bangladesh and Pakistan to look at the impact of smoking cessation in TB outcome, whether there is any added value or not. So if you look at the success rate and the relapse and sputum conversion rate. So the TB treatment, the success rate is quite high among the quitter compared to non-quitters. And most important, the TB relapse. The relapse is almost double among the non-quitters compared to the quitters. So that means we need the smoking cessation program within the TB as a first action that would really prevent the relapse rate. That means we break the chain of transmission of TB in our community. And it has a really great the impact in overall at the population level. So this is almost my last slide. So we need, as I mentioned earlier, I think in a TB control community, we have a greater technical capacity. We have now technology, we have the resources, we have medicines, we talk everything, but something is missing there. We need to think out of box, or we don't need the box at all. I was trying to put the box here, but it's still box with the line. But say no, we should throw the box. We don't need the box. But what do we need? We need action. And action as I mentioned, in our setting, when I say our setting, in this part of the world, in a high burden setting, high burden TB and tobacco setting, what we need the first thing, we need the local or national legislation to ensure that all level of governments, all level of the civil societies, and any of the stakeholders, we need to make them accountable. That is really important. And we can do only through the legislation. It needs to be clearly defined. When we talk about the law or any legislation, what does it mean? It means it's a mandatory. If people don't follow, there is a sanction. Without sanction, I don't think we can. In tobacco control, we don't have any hope without any legislation. We need legislation, and we are working on that, and we are making good progress. Same thing in TB control, I think we need as well strong national legislation that mandates the clear role and responsibility of all the actors, including resources, from domestic resources, especially. When I talk about the resource, that means domestic. So these are something that I would like to really. These are the questions to all of you. Let's discuss. But again, when we meet next time, we are thinking yesterday, Dr. Lini and me, and Okada, we talk whether we can make some good symposium or something in our next World Conference when we meet in Denmark next year. So I hope we can show something concrete at that conference as well. So this is our goal, right? Guy Marx always used to say, we need to do the early. If you are going to eliminate tuberculosis, what we need to do? We need to find the people as early as possible. Not only we find the people as per our comfort. Oh, I just want to, this is my catchment area, why I want to do this. No. We need to go beyond that, like a mass screening, mass campaign. We need to have early diagnosis and early treatments to really break the chain of transmission. I think that is the clear goal of the union. When I say the union, we all are as a union family. Union is the family that has a clear vision to eliminate tuberculosis. So these are these all are the things that I just made a presentation. It's a question to all of you. So I would really like to have some discussion here. Yeah, over to you. Thank you.
Thank you. Dr. Baum have so many knowledge, so many experience, and so many insights for sharing for us. To be frankly, although I have been working on tobacco control field for over 20 years, I didn't pay extra attention to TB, most focus on NCD. But now, what you have shared have opened a new window for us. I know that in China, 20% of TB occurrences are attributable to smoking, and 25% TB-related deaths can attributed to smoking. And it's not only related to the occurrence of the TB, but also related to the delayed treatment, the delayed diagnosis, both the smoking and the passive smoking. So I really learned a lot and really appreciate it for that. Now is the Q and the A discussion. I will combine both the online and offline, but also offline first. So if you have some questions, please make a brief introduction for yourself and then brief your questions so we can have some discussion.
Yep. And also, I have a question to all of you as well. Yeah, if you don't ask, yes.
So there are so many. So let me one by one. So for this gentleman, okay, you first. Thank you.
Thank you for naming me, gentlemen. Thank you. Thank you very much. Good morning. My name is Thamer Al-Hilfi. I came from Iraq. I'm a national expert in NCDs and tuberculosis. In congruence what you were saying, sir. In the first day that we came here in the conference, there was a very, nice presentation from the President of the UN and a special slide that was saying that facts about tuberculosis. One of them is that equity, since 1974, we are suffering from equity and equality. So now I'm coming back to your presentation. One of the slides that we're saying, the bar chart, that delay in diagnosis. So there was the smokers, it was, if I understood it well, 120 days. The ex-smoker, 103, you are making my life easy. Never smoked 80. So I will take it from the other side, that even the non-smokers, there is 80 days delay. So it's a very significant.
Yes.
So once again, working in solo, even if the leadership inside the countries are doing well, this will not lead us to the equity we are looking for. That is equality to access, and if we are going to diagnose, let us make sure. And this is in reality, it's not there. So working on the, let me say, the risk factor is very important, and for the smoking is also very important. But we have to be having a clear message, and that equity should be prevail to our communities. Thank you very much.
Yes, Dr. Lee, you have some response on that?
Dr. Lee and Okada, I think okay, you want response, right? Okay, Linian, please.
One point.
Please.
This is Linian from the union. Thank you very much. Tyra gave us a very good presentation to give us plenty of evidence and information, make us confident regarding to acting as not only leadership but also the capacity building and follow-up actions to address the co-epidemic of TB and tobacco. I just want to add one point. Tyra already pointed out the evidence regarding to the TB relapse, TB recurrence between non-smoker and smokers. I just one point is that we have done a longitudinal one to follow up a group of patients, TB patients, who already successfully complete anti-TB treatment. And then this cohort was followed up for 7 years to see during the TB treatment, we give the ABC, the support, and someone quit smoking, and someone not quit smoking, continue smoking, to see who have more risk of TB recurrence later on. So what I can tell you, the people receive the cessation intervention program, and successfully quit during TB treatment have a lower risk of TB recurrence later on. So this will add a confident point that is smoking cessation for current smoker is effective to prevent the later long TB recurrence. Thank you.
Thank you, Dr. Lee.
Yeah, it's an excellent point.
Okay, maybe the gentleman agree.
Tara, thank you so much for your great presentation. So, in terms of the smoking cessation program, I mean, like a brief smoking cessation program. So, 15 years, it's now 15 years after the publication of that green book. So, two great missing things I find. So, that one is the novel tobacco products program. So, like we have to take into account the e-cigarettes. We have to take into account the HTP. We have to take into account other like tobacco products. So how can we, fit in to the guide, ABC guide? That is a big question. Another one is how can we include the NRT or pharmacological interventions? So of course that the ABC documents mention about that, but we have to modify it, perhaps. Taking account the new documents of WHO that for the clinicians, the frontline clinicians just document published 1 month ago, 2 months ago, I suppose. So we have to take into account that big area that we are missing, perhaps, basically. So that is the point that we have to take, especially for the new area, new tobacco products, novel tobacco products, we have to take it because it's now converting from the conventional tobacco products to the new novel tobacco products. This is a big issue. It's really, 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 I can say, challenging area we are now facing. So all of the tobacco and TB control program, we are facing the big issue. So.
Yep.
Thank you, Dr. Tara, for the very comprehensive presentation. I'm Sharan Gopali from Nepal. Yes, in my country, we are from the same country. NTP Nepal have already incorporated this tobacco cessation in our TB modular training. My only concern, as we have also running as an NGO, the TB clinic, so utilizing ABC approach, if we can make some kind of behavior change, tools for the healthcare providers also every day, because they are busy with the medication recording, reporting, and if there is some visualization, that reminds both in the patient side and from the healthcare provider side also. That's also one of the gaps why I think not all the TB patients get the necessary informations. This is the ground reality.
Okay.
Thank you very much.
Maybe before some of the I think I need some clarification some of the question. Thanks, Dr. Linet, for your you added some more the value and that why we need the smoking cessation. I'm very happy, sir, that you raised the equity and equality. So that is, of course, what is our dream? We want the TB patient or people in our health facility as soon as possible, in a day or in 2 days or in 3 days. So we need to also really significantly cut down the health-seeking behavior. Actually, that is something. It's a big issue. We need really some mass campaign about TB. What we are doing, of course, I can see as social mobilization, communication, something going on, but it's not like it's a mass campaign in any country. I haven't seen that one. So we need to really have a mass campaign, like you identify the clear message there should be there. How can we, bring all the people who need the TB services as soon as possible in our community? I think that's a really important point. So equity and equality are a big concern. The second, another Okada that you highlight the issue, of course, intentionally, I didn't put that slide or the information about vaping. That was my big question also. That was the question to all of you. How we are going to address this new challenge, new problem, the vaping, electronic cigarettes. Some of the public health community, we can see the different voice. Some they say, or they say this is something a smoking cessation device or tool to help, or there are some different opinion. But what we see from the tobacco controller, from the scientific organization, including World Health Organization, is vaping is also a significant health problem. We need to also do something about that. So what we can do at the TB community, that is the action again. So it's a big issue at the national level, it's a global issue, but something we can do in our community, that is at tobacco and TB community, especially TB and tobacco. I think that in a guide, we can also incorporate some, just to review the existing evidence, and we can try to feed in our revision, the ABC guide that we are planning to have some revision, and also launch this in upcoming any one of the conferences. I think that is something we can do. And then what's your second question? Sorry. Pharmacological. Yes, that's my also one of the key agenda, advocacy agenda. When we talk about the NRT, so we don't want to keep this in one isolation. Not like you refer the patient to go there to buy the NRT or to get the NRT. So it needs to be integrated within the package as well. And there are opportunity. One, the immediate action that we can do in a TB package. So we have a medicine, we have all the services there, so NRT should be included. It may not be for everyone. NRT can be included within the TB control package. One of the recommendations that I have seen from Philippines Joint Monitoring Mission, one recommendation they have mentioned, they put there, I think that was a 2019 or 20 Joint Monitoring Mission, the NRT, they recommend the governments NRT should be included in a standard TB care. I think that is a really good point. And something is happening in Indonesia as well, whether the NRT can be integrated within the universal healthcare package. I think that is the best opportunity for all of us. And it's a WHO agenda as well. It's a concern for everyone. So I think as a TB and tobacco control community, we need to work together with that. That's why we need the leadership skill and quality now. See, beyond the box or through the box. So universal healthcare is one of the best opportunity for all of us to ensure the NRT is included in that package. Maybe there are some, we have to also come up, we should have further discussion on this as well.
Thank you very much. Thank you, Dr. Tara, to bring me back from the...
I hijacked him from that room to this room, yes.
Because I was on the show because my friend will present here, and that is finding missing cases. So coming here, I feel really very much honored, and I feel that now we have to think out of box actually. Because finding missing cases, they are already suffering from TB. But cessation tobacco is something we are preventing for TB. So, in fact, if you see the WHO 2024 guideline, you will see nutrition, tobacco, diabetes, HIV. These are the 4-5 factors which is the risk factor for tuberculosis globally. And as Tara presented, like China or some countries, even tobacco is the number 1. Bangladesh, tobacco is number 2. Nutrition is the highest. So, I'm working for TB since '89, before the DOT strategy started actually. So, since '92, Bangladesh initiated DOT strategy, and I tell you, until today, our incidence remain flat. We detect every year 300,000 TB cases, over 300,000 TB cases, among our incident about 379, but our incidence is not coming down because the other risk factor we are not addressing. The nutrition problem is there, tobacco problem is there, diabetic is there, many other factors is there. So I think it's very important that that we need to think for TB control or bring down the TB globally out of box, like improve the nutritional status in the country or cessation of tobacco, addressing other problems side by side. So thank you very much. That's my comment, and thank you to bring me back here.
Thank you, sir. I think that's a great point also.
The gentleman in blue, sorry for.
I just want to add here, the nutrition, he touched upon the nutrition as well. I think any of the session I attended, I hardly see some of the discussion around the risk factor. So when we talk about the nutrition, we need the good food, right? Balanced diet. To have that, we need money. And we need money, and we need to either we have to earn or we have to save or something. If you look at in TB community, people who smoke or who drink, if we offer services or counseling or message to quit smoking or to quit also the drinking, so the patient can save money. They can save money significant. In Indonesia, I don't know in other country, Indonesia, the smoker on average, they smoke 15 cigarettes per day. 15 cigarettes. It's almost a pack. You know how much it costs? A pack of cigarette in Indonesia is about $2, something like that. Okay? Every day, he or she spend $2 to buy cigarettes. So if TB community, you talk about, the patient, we talk about, right, the problem in transportation, that there is no money, it's very far, and all the things. We have to think this way as well. How to help the patient to save money. How to save the money? Quit smoking, quit drinking. They can save easy message. It doesn't require any additional resources. Just we need to frame the messaging in our standard TB care. I think that's something we need to also do. Yeah.
Okay, thank you. My name is Hario from Indonesia. I'm a lecturer in the Faculty of Public
And my
Health.
boss also.
First of all, Tara, thank you very much. I'd like to express our gratitude from Surabaya citizen. You support us in tobacco control program in Surabaya in particular. I have small comment from your presentation. Just one small puzzle that you mentioned in the last slide that about legislation. I think one of the factor that City of Bogor successful is also the law enforcement movement. So the commitment of the mayor to enforce the law, I think is very great, and that is the one of the biggest impact in the tobacco control program, how to enforce the law. So not only the legislation, but also the law enforcement. That's on my small comment. Thank you, Tara.
Thank you, Hario. I think it's a good comment.
Good morning. Thank you for presentation. I'm Suman Al-Fazazi, the MTB manager of Niger. I'm very happy, like you say that we can do veritable legislation in our countries to bring the tobacco industry, because in our country, the poor countries, because of money that tobacco give to the government, they have problem to take veritable legislation to combat tobacco. So that what can we do to bring our government to take veritable legislation to do the health of the people, not to regard to the money that tobacco give to the Ministry of Finance, Financial Ministry. I want, if you have some ideas to convince our government, so that I will take this to go to see them, to tell them that tobacco is not very good for our countries, but increased TB cases and other diseases in our countries. Thank you.
Just a quick response for this. There are always arguments from tobacco industry side or from some of the policymakers who closely work with the tobacco company or something, or work for their vested interest. Or the companies, they pay the high tax or revenue. Tobacco is one of the main source of revenue. Actually, it's not from the tobacco company. Who pay the tax is the smoker, the person, the individual. I think we need to change that narrative. It's not a company. Company gets profit. And the tax, the revenue that goes from the smoker, that is something, it's not a company. So that is something we need to also change the narratives. And in some of the countries, we are quite successful doing this. Many of the ASEAN, in our region here, and also globally, the governments increase the tax significantly. For example, Philippines is a good example. Even in the Indonesia, it was quite cheap before. Now it's getting much better compared to in the past. So all the governments, many governments, they recognize that tobacco taxation is one of the key public health intervention to address the public health, especially the NCDs, now also the communicable disease. And also it is also it's not a long-term source. The long-term is end TB and tobacco, right? That is our goal. So, but in a mid-term, so it can be one of the potential source of funding for the public health program as well. So like this, therefore I mentioned the Nepal, it has established a national health fund, and the money comes from the Ministry of Finance, from the tobacco tax and alcohol, and also Thailand has a very good example. They have also the national health fund. Singapore has, Indonesia is one of another good example. So the many countries now they are trying. I'm sure they are, there are many evidence around the world, so you can bring, or if you need, we can also help you to provide some more evidence. Yep.
Okay, I have to end this session, and what a lovely morning session. We have learned so much. Let me thanks again for Dr. Ban for your wonderful speech.
No, I'm really surprised. Thanks to all of you. I had also one session like in a long time back in Paris, like a meet the expert at the early morning 8 in Paris. And how many audience, how many people there? Me and chair. That's all. So it's and this time I also when the committee approached me to have this session, I said no. Yeah, I can do it, but don't expect too many participants in there. But it's really great to see all of you, and it's almost a pack of. Thank you very much. Yeah.
Thank you.